Good evening. Good Saturday evening. Well, week 8 starts tomorrow, and I wanted to go ahead and it's been open, but I wanted to go ahead and do the walkthrough so that you could get started working on things. If you wanted to do so, I will flip it over to be the front page. But right now I have it taking this from the module. So we'll do a walkthrough. Let me view this as student. And we'll go through the overview, and then we'll go through the assignments, and then I'll go through the lesson. I was finalizing that last night, so that page was not available, but it is good to go now for those of you wanting to move forward on that. So this week, our final week, we'll kind of be pulling a lot of the themes and terms together. When we talk about global health perspectives, we're going to talk about global health and US responsibility, or how do we help? How does our health system compare to other countries? And we're going to look at that using the lens of infectious disease at home and abroad. So infectious disease in the United States, as well as infectious disease, for example, like COVID, in other countries. So that is what we are looking at. And we're looking at in terms also of how social justice plays a role, right? So in our country, we've been talking about that for the past 7 weeks. Now let's talk about what does that look like in other countries as well? And are there, for example, international health organizations within the United States that help in disease prevention and health promotion, looking at different countries' approaches, which is one of the assignments that you'll be working on. How does the US engage in global health efforts? And then looking at evaluating global and national policies that aim to reduce the burden of disease. That would be like the Affordable Care Act, or in terms of universal health care versus single payer sources, and apply lessons from other countries to address inequities in the US healthcare system. So when we compare and contrast other countries to the United States, where do we fall? Are we higher? Are we one of the better providers of care, in the middle, at the bottom? Where do we fall? So it would be good for you to sort of think about, as you begin the lesson, where do you think the United States falls in comparison with other countries? And we will come to that throughout the lesson and as we recap at the end. So we're going to be talking about global health disparities. We've talked about disparities in the United States. Now we're going to talk about them, and we will see them in the world as well. Because again, if we look at the countries, poor or marginalized communities in other countries are very similar to our poor and marginalized communities in the United States. And so we're going to take a look at that. Universal healthcare, a healthcare system where all citizens have access to essential health services without suffering financial hardships. So we're going to take a look at that. Single payer systems, we'll look a little bit at socialized medicine, compare and contrast those. And what does that look like? And then globalization and health. So when we talk about globalization, we're talking about the globe. We're talking about the entire world. And so the way that international trade, travel policy decisions affect health worldwide, a lot of different policies, immigration would be one. The way that we travel, are there, bans on traveling? Do we have to be healthy to travel? We did with COVID-19, but we don't, people aren't checking that anymore. So are we still at risk for certain diseases? Infectious diseases, right? Diseases caused by pathogens like viruses, bacteria that can spread person to person or through the environment. And chronic diseases, right? We think about infectious disease in terms of, well, if I travel here or there and I don't get my vaccines, then I might get sick. In fact, you can't travel to some countries unless you can show proof of vaccination. But what about chronic disease? Do they have diabetes in other countries? Do they have hypertension in other countries? What does that look like for them? Or even worse, do we have a double burden of disease where a country faces high rates of both infectious and non-communicable, like chronic diseases? So you might have a lot of HIV, but as well as diabetes and heart disease at the same time. So then you're combating different types of illnesses that may require different types of prevention strategies as well as treatments. And then finally, the final key concept would be international collaboration, collaboration between countries, organizations, agencies working together to address global health issues and share knowledge and help to coordinate, find solutions, fund solutions, those types of things. And so there is a list that will show you different organizations and how they work. And so here are your readings with your links to those particular resources. There are some web pages looking at different statistics around countries. Global Health Watch is another one, and then also some reading about acute and chronic illnesses. Let's look at the assignments for this week. So what you will do is you have a free write about the U.S. role in global health equity, because we're also looking at equity as an issue as we talk about the United States and comparing and contrasting with other countries. And so it'll be very similar to the first one that you did. And so you're reflecting on your understanding and or personal experience of the United States role in global health. So not just as funder, not just providing money and resources to crises or other countries, but as a powerful force that can either support or undermine health equity worldwide. And so there's not really a wrong answer, right or wrong answers. Make sure that you respond in appropriate amount of words, like at least 300 words, and answering these questions, right? What's the US's current role in global health? Now, you may find these answers in your readings. You may have to do some of your own research and looking at credible sources. So that's all good. But here are also some things to think about in terms of a lot of these things are in the actual lesson. And so how does the U.S. help or harm efforts toward global health equity? Should U.S. have responsibility to support health equity? Why or why not? What do you think the U.S. could or should do differently in the future? And so 300 to 500 words can be more, not less. Just paragraph due by August 1st. Watch your due dates for week 8 because technically the semester ends on August 2nd, which is Saturday. I will accept assignments until August 3rd, which is Sunday, but the assignment due dates are a little bit staggered in week 8 to keep you on your toes and to also provide time for you to complete your capstone. So there is your rubric, and there you go for that particular assignment. So let's go back and look at the comparative health systems. Oops. Here we go. Click on the right one, comparative health systems worksheet. So for this one, you're going to choose 2 countries, one of which must be the United States, because that's where we live. The other can be from any region, Canada, UK, England, Ireland, Rwanda. There are some countries, we have South Korea, a case study about South Korea and a case study about Rwanda in your lesson this week, and using credible resources and to some optional sources, things to look at. And so you're going to complete a health systems comparison table and then do a reflection. So the health systems comparison table, United States, country of choice, what type of health system do they have? And you literally can cut and paste or make your own table that's like this and put that into the assignment. Who provides the care? Public, private, government? Who pays for care? Individuals, government, employers, percent of the population with health coverage. You're going to have to look at some of the statistics. There's a lot of different resources in the lessons that you can use to look there, as well as these resources here. And then key health indicators. So we actually in the lesson, I believe in the last tab, talk about life expectancy, infant mortality, and where does the United States stand, and where do other countries stand? And understand that yes, the United States is bigger, but we gauge it based on what they call a per capita. So it's kind of like an average based on how many people live in the country, and that's how they kind of equalize it a little bit. Top 2 public health challenges, role of government, equity of access. Do most people get the care they need? Strengths of the system, any weaknesses or barriers to care. And so you may find that the United States is really good at all those things and the other country isn't. You may find vice versa. You may find that it's a nice mix of things. So it just depends. So you're going to complete that chart and then do a reflection, complete a reflection. So what did you think? What did you find from your research are the most significant differences between the two systems? And how do those differences impact health equity and outcomes? I will tell you right now that the United States is not one of the countries that provides health equity in their care. We're not even in like the top 10. And what surprised you about your comparison? What lessons could we learn from other countries? What lessons could other countries learn from the United States? And so just submit your chart and the reflection in one document or two, whatever works for you, three credible sources, due by August 1st. And then we'll go back and look at the discussion. The last discussion number 4. And for this particular discussion, make sure you go ahead and hit subscribe. I believe I added the rubric. Let me make sure that I have the rubric there. Oh, I will change that to discussion number 4, but it will be the same rubric. I always notice something when I do these, which is good. It's a good double check for me. So as we wrap up the course, I would love for you to take a moment to reflect on what you've learned, how you've grown, what you're taking with you. It's your opportunity to look back at any key themes that you thought were interesting, concepts, projects, assignments, anything that we explored together, and share what made the biggest impact on you. So you have an initial post and 2 peer responses replying to 2 peers due by Saturday, August 2nd. There is not a due date to post your initial post and then come back and do peer responses. You can do it all on the same day. However, because again, the due date is August 2nd, it behooves you to post your initial response earlier in the week so that everybody has a chance to respond to 2 peers. Otherwise, say if I put my response in on Monday, everybody's going to respond to me and nobody else is going to get feedback. So try to post as early as possible. The initial post and response to the 2 peers is due Saturday the 2nd. And so in your initial post, here are at least 250 words to respond to the following. So what were the most important or meaningful things you learned in the course about health and social justice? Because that's what the course is about, health and social justice. Include 3 things, describe in detail with examples. So inequities that we talked about, public health systems, advocacy, community organizing for your project, any of those things. Number 2, which assignment, activity, or discussion helped you understand those ideas best and in what way? Which weekly lesson or assignment outcome were you able to meet? So go back and look at the weekly lesson objectives and outcomes and see which one you feel that you were able to meet. And you might want to take a look at this week's assignments that we just looked at to see if maybe one of those you might find affected you in some way. How have your views, awareness, or understanding of public health and social justice changed? When new questions or interests did the course spark for you? Like maybe with the advocacy projects or writing your congressman or somebody, does that make you want to do more, explore more, or maybe look more closely at public health as a career choice, maybe even? What personal beliefs or values did it reinforce? And then choose one course objective or student learning outcome. So a course objective or a student learning outcome. So those are found in the syllabus. They're also in the lessons. And explain how you met it through your own work. You can refer to a specific assignment or a moment from the course, but how did you personally meet that course objective or student learning outcome? And then moving forward, how will you take what you've learned in the course and make a difference in equity and social justice for yourself or others? And then reply to at least 2 classmates, supportive comments, share takeaways, very much like you have been doing. You guys have been so supportive in your discussion responses to each other. It's really been amazing. And so I did go ahead and post the course objectives and also the 3 student learning outcomes for you to, they're right there for you to take a look at to answer question 4. So that is the discussion to kind of bring everything around full circle. And then your final social justice journal entry, and I did update the assignment to reflect the key concepts that are in the lesson and the questions to answer. So the first and second question are the same question, just worded a little bit better for clarity. And then the third question is a new question. So you would need to add that to your journal. And then there is the description of the criteria. And like I said, I'll go back to the discussion and put in the correct prompts or correct rubric for that. Let us take a moment to also talk about community organizing and advocacy capstone project. This is due on Sunday, August 3rd. It is worth 100 points as opposed to a final exam. And so again, we have talked about it in other walkthroughs, but let's just review one more time. And then if anybody has any questions, please reach out. You can reach me via the chat. You can, make student hours appointments. Rarely have students done that. I'm available. That's why I'm here to help you. And so feel free to make appointments. If my calendar doesn't work for you, then message me or email me and we'll find a time that works, that fits both our schedules. So we're covering objectives 7, 8, and student learning outcome 3 in this assignment. And you can do it, you can present it in terms of a paper, a presentation, either recorded or live, an advocacy package. You worked on policy briefs and letter to a policymaker, or it could be like a creative project, something like that, with a written explanation. And so your project should include what is the issue, because the point is we're going to advocate, right? There's hopefully some issue that you felt strongly about that you want to, it's a problem, a public health problem. Who's the affected population? What are the contributing social determinants, structural determinants? And how do you want to make a difference? How can you advocate to promote social justice and equity as well as health? And so organizing or advocacy strategy, explain, a lot of this is from week 6, right? Which is why I switched those weeks for you so that you would be able to have the information you needed to complete the project. And so past or proposed community organizing efforts, advocacy strategies, policy changes. So are there things for your particular issue that have happened? Have people tried to advocate? What's worked? What hasn't? And so then what do you want to do? What strategy do you think will work? And what will your role or plan be? How would you take action? What are you going to specifically do? Identify challenges, explain how your approach supports equity. Remember that you don't have to actually implement this. However, you may find the information interesting. You may, in further studies and further career paths, find that this comes in very handy because you did the research on it. And so are there any challenges? Are there languages? Are there social barriers, education? If you are working with community partners, how easy or difficult is it to get a hold of them, to find venues, to whatever it is? And how does your approach support equity? How are we going to get this information out to the people that need it most? And then what's the call to action? What do you want your audience to do, support, or advocate for, right? So we want to, I don't know, write letters to to a policymaker. We want to, I'm trying not to say let's go down and protest, but I mean, that is a thing we could do. That could be a call to action. But I would say then have, some kind of education available or, something that pulls it all together with facts. Include a letter, the flyer, something that you've, whichever advocacy strategy you're choosing, and then at least 3 credible sources, including at least 1 community-based or local resource, and then cited in APA or MLA format. These are different topics. There's different advocacy ideas here. If you click on that, it will take you to some different ideas. Again, you don't have to choose something from this list. And then here is the point breakdown. And then you would upload it. So I am curious and would love to know what people's ideas are from what I was reading in the week 6 discussion, which I will go back because several students completed everything on time. So I tried to respond to as many as I could. I have time now. I will go back and respond to the students that I did not get a chance to respond to provide some feedback or ideas for you. I will say that students we're doing a wonderful job of supporting each other and providing references and websites and all kinds of different information for each other. So that's really important, and I really appreciate that. You can also get a hold of each other through the class chat if you want to get a hold of somebody in case you're working on similar topics. I think that would be amazing. Okay, reflection journal we went over all of that. Yes, we did. Okay, so let us turn now. Let's go back to the module page. And let's just quickly look over the week 8 module, make sure everything is there for you. So we just looked at the overview. We are going to move to the lesson next. I gave you the discussion of which I will make sure the rubric is correct. We reviewed your free write and your health systems worksheet and we clarified the social justice journal for week 8, and we also reviewed the capstone project. So that's great. So Petunia, sorry, she's barking. And so let's move on to the lesson. All right, week 8 lesson. Hey, psst, come here. What's he gonna do? What do you think? Hey. Okay, sorry about that. Alrighty, so here for the lesson, you will see we have 5 tabs. So we are going to, this will cover a lot of those key concepts that we're talking about earlier. And we'll also recap, bring it all together with some interesting facts on the last one there. So we want to talk about global health. That's what this week is about, global health perspectives, different ways to look at different things in terms of global health perspectives. Let me grab my dog. Was that Uncle Ian? We should be barking at Uncle Ian. Come here, come here, come and say hi. Okay. There we go. There's Petunia. There you go, Petunia. All right, so we've explored how health has been shaped, right? We talked about social determinants, structural determinants. We talked about economics and education, all different kinds of things, right? And so now we're going to bring things out from a global perspective and kind of see what are some challenges that the world has, that we have as a country and other countries have, and what different approaches do different countries have, and what resources do we have available to us. So let's go ahead and the definition, right? Field of study and practice focuses on improving health and achieving health equity for people worldwide. So that's what we've been talking about, social justice and equity, and now we're looking worldwide. Involves understanding health problems, the people's responses, countries' responses, communities' responses, and outcomes across countries and cultures. So core features of global health would be that it's equity focused, right? We aim to reduce the disparities, even in other countries. We know we call them third world countries, or we say first world problems. Third world countries, some countries don't have the resources, but that doesn't mean that they can't think of creative ways to meet the needs and try to be equity focused. And so hopefully other countries can help as well. It's collaborative, right? Governments, nonprofits, the communities, healthcare providers, nurses, doctors, all kinds of different healthcare providers. And it's interconnected, right? We notice that disease, healthcare, and policy cross borders, right? Everything's, and especially nowadays, the world is so interconnected. We are a plane flight away, hours away from a country far, far away. You have a YouTube video there to watch. And then having said that, looking at infectious and chronic diseases, right? So we talked about those definitions and why does that matter? Because if a country has, disease threats, I don't want to say this. So sometimes the country can only focus on, say, for example, a pandemic or something that's a disease threat as opposed to a chronic disease or other types of like HIV kind of type thing, other viruses. Or they have to deal with chronic illness. But a lot of low and middle income countries now face both disease and chronic, so infectious disease, chronic disease, and fragile health systems. So they have health systems that are not working well, they're not funded, are difficult to find providers, all those kind of things, and they're dealing with infectious diseases and chronic diseases. And so the health outcomes do vary between countries and even within a country like Africa. Africa is a continent and a country. Well, it's a continent, it's got many countries within it, but even within a country in Africa, or within the United States, right? We are a country, but within different states, we can still have disparities, and it varies drastically. For example, maternal mortality, we're going to show you a chart later on here, is 120 times higher in some African countries than in what are considered wealthy nations like the United States. Children lack access to vaccines for preventable diseases like measles, which has pretty much been eradicated in the United States. And then people in low-income regions are more likely to suffer malnutrition and unsafe drinking water, which we don't even really, we talk about it, but I don't know, it's not necessarily top of mind, I don't think, in the United States necessarily. And then the structural causes we do have. I think all countries have poverty. There can be weak infrastructures in certain areas, different colonial legacies, political instability. Many countries are still at war, right? We're in a time right now where there's been a lot of different wars. What about people in Ukraine, Russia? What type of health problems are they going through right now? So there is a World Health Organization, WHO, as they call it. There's a link there for you. And so what is our role, the United States role in global health, right? We have a complex, but sometimes contradictory, I guess, role in global health. So we're a large contributor of aid, but we struggle with our own domestic health inequities. So it's kind of like, why are we telling you what to do or providing you with money when we can't even do a very good job of taking care of our own people in our country, and we don't have equity? We have high African American maternal mortality rates. And so we do contribute, right? We fund USAID, which actually is going through defunding right now, but what's being defunded is being parceled out to other entities, and CDC, Global Health, the National Institute of Health, different things like that, different facilities, organizations like that are able to provide education and funding. Focus areas, we talked about maternal child health, pandemic, COVID responses, vaccinations. Vaccines are a big thing, as well as HIV/AIDS. HIV/AIDS, where people still can move from HIV to AIDS. The HIV is the virus, the human immunodeficiency virus, versus the acquired immune deficiency syndrome, because of the research that has been done and medications that have been discovered. People can even be what they call undetectable. You might see those ads on TV, but there's still a risk of that. So we still have to do education. And then different partnerships, right? With the World Health Organization, Gavi, you'll read about that, has to do with vaccines and local health systems that we have. But keep in mind that the US spends more on healthcare on our, per capita for our people, our citizens, than any other country. And there's some statistics that you'll see in a later part of the lesson. But we have some of the worst health outcomes among high income nations. So we spend the most money, I believe, I want to say we do that in education too. We spend a lot of money on education, but we don't have very great outcomes. And so here's a short little 7-minute video that talks about that as well. And so who does pay? Where does all this money come from? Right? And so who pays? A lot of international societies, organizations fund. That'll be on the next part of the lesson. We'll talk about some of those lists there for you. And there's a lot of research that goes on looking at disease surveillance, trying to do health education, how to figure out how to do critical responses, emergency responses. What does that look like? For example, COVID. How did we respond versus how did other countries respond? And did we have better outcomes or worse outcomes than other countries? And so why is global health funding, why is that a social justice, health justice issue, right? Because the low income countries can't afford the infrastructure, right? So they're depending on other people, or they don't have the mechanism. If it's a widespread, fast moving disease, it's difficult for them to stop it, to eradicate it. Malaria, tuberculosis, they are preventable and treatable, but still kill millions because of resource gaps. We can't get the medications where they need to be. We can't educate people like they need to be educated. Power imbalances, right, affect who sets priorities. Donors might focus on certain diseases while overlooking local needs. So a lot of times you'll see, I'm supporting this, excuse me, or somebody, a person or an organization is focusing on, I don't know, Parkinson's is what comes to mind. It could be anything, cancer. But I'm just thinking because Ozzy Osbourne just died and he had Parkinson's. Michael J. Fox has Parkinson's. My dad had Parkinson's. So it's just kind of top of mind for me right now. So we focus on Parkinson's, which if you look at statistics, although it does affect many people, it's still a very small number versus what would be local needs, right? Things, food, shelter, clothing, things that are needed in our communities, disease prevention, access to healthcare, access to vaccines, education, all those types of things. And we do have a moral and a strategic interest to prevent disease abroad, because if we keep people healthy, they'll be healthy when they come to our country. People in our country will be healthy when we go to other countries, because people do a lot of traveling. I think I have 1, 2, 3 friends from different parts of my life that all went to Italy this summer. So I thought that was really interesting. And then global health funding, right? Financial support from could be governments, could be nonprofits, could be an international organization. So different examples of government donors. We're still the single largest donor, 10 billion annually. I'm sure it's more than that now. That was of 2023. And funds flowing through USAID, CDC, PEPFAR is the President's Emergency Plan for AIDS Relief, the Fogarty International Center, that's a center associated with the National Institutes of Health that promotes research. And so that would be a government donor. I will say that through with the new administration and DOGE, we did see a lot. I think eyes were open as to where funding is going. So hopefully funding can be routed to the correct, most needed areas. And, in our country, I would think, as well as internationally, but to be more focused focused and equitable in order to improve health outcomes. So multilateral organization, so things through multiple countries. So that would be an example, would be the World Health Organization. That members sit in that organization from countries all around the world. Gavi's the Vaccine Alliance. I alluded to that a little bit earlier. There's a global fund that fights AIDS, TB, and malaria. The World Bank. Again, you'll have all these explanations on the next page. But Gavi, for example, pools funds that are donated to provide vaccines in countries that couldn't afford them, right? So they've had over 1 billion children immunized since the year 2000, which is like incredible. We kind of think, I guess I kind of think, I would take my kids to the doctor. They're all in their 20s and 30s now, but when they were kids, we didn't have near the number of vaccines that we have now. Two of them never got the the varicella vaccine. One of them did because that was, a new vaccine at that particular point in time. Um, and he actually ended up getting chickenpox like 2, 3 weeks after he had the vaccine, but that's a whole nother story. But being able to do that because they're preventable. Those illnesses are so preventable. So this is an amazing thing. And then private foundations, for example, like the Bill and Melinda Gates Foundation, right? They give money. They have so much money to give. They give so much money. It's just like amazing. The Wellcome Trust, that is the correct spelling of that. Clinton Health Access Initiative is another one. The Gates Foundation funds malaria research. Polio eradication. We don't really have polio in the United States, but in other countries we do. I think maternal health programs really need help, especially they mention here Africa and South Asia, but in the United States, we do too. We have a terrible maternal mortality, meaning moms die, and infant mortality rates in the United States. And so this is just different program areas and things why the funding is important for those. So that's sort of the basics in talking about global health, right? Global health. Where does the money come? Well, yeah, where does the money come from? Where is it dispersed? How does all that work? So we did mention some global health partners. So that's the next part of the lesson. And so I wanted to give you an idea of specific agencies in the United States that are involved in global health, and then as well as worldwide agencies. And so most of these programs, if not all, have there's different components on which they focus. Some are just prevention, some are just research, some are strengthening health systems, some actually combine all different kinds together in their organizations. So in talking about USAID, United States Agency for International Development, there's the website there. And what it does or did or will do through other entities now is the lead U.S. agency for international development and humanitarian aid. My question would be, what does international development mean? Humanitarian aid, I know what that is. And its Global Health Bureau works to save lives, strengthen health systems, promote long-term health equity, right? Especially in low-income countries. So I think that is a great thing. I added down here USAID programs now being run by the State Department as the agency ends operations. There's an article for you to read if you would like to learn more information about how that funding is going to be distributed now. And then the key focus areas, which I think are great: maternal and child health, family planning, reproductive health, the HIV, malaria, TB, emergency response and disease surveillance. That's really important. NGOs or non-governmental organizations. CDC, right? Centers for Disease Control and Prevention. I think everybody's heard that name, is familiar with the CDC. There is their global health page, or you can just go to cdc.gov. And so the global health, this is a global health piece of the Centers for Disease Control. And so it protects people in the US as well as globally. It detects, does prevention education, responds to infectious disease threats. So for example, during COVID, they came out with recommendations for how to, different interventions, how to detect it, different policies and procedures, those types of things. And so it partners with other countries to build public health infrastructure, like to set it up, to train professionals, monitor outbreaks. The thing I like about CDC is, especially their website, is they have so much education information. Like for example, for vaccines, there is an app that you can get from the CDC that will actually that has the vaccine schedules on it, so you have it at your fingertips, and they update it every year as new things and new regulations occur. And I love that. And they also have like a growth and development app, a lot of different apps. I just know those because I use those in my other life as a nurse and education in the nursing program. So so I love their education component. And they work a lot on disease surveillance. They do a lot of research and outbreak responses. Measles is not on there. Measles, Ebola, COVID-19. health security, pandemic preparedness, like as I mentioned, COVID, the immunizations, really a lot of immunization program information. They do epidemiology training. So I think we touched on that a little bit in the first couple of weeks of the course. And they have classes on how to be an epidemiologist, how to I sort of think of epidemiology as the Dr. House of public health. There's something going on, and what is the research? What facts do we have? Let's figure out, what's going on here, as well as health equity and non-communicable disease prevention. So it works in more than 60 countries to come up with all these statistics, which I think is amazing, and to help respond to crises. So PEPFAR, I honestly wasn't that familiar with PEPFAR. It's the U.S. President's Emergency Plan for AIDS Relief. And so that's where its focus is on HIV, AIDS prevention, education, treatment, care, mostly in sub-Saharan Africa and other high burden regions, because those areas have like little to no access to healthcare. And so healthcare or treatments. And so that's why that is so important. They've apparently saved over 25 million lives, which is just amazing. Dramatically reduced the new HIV infections worldwide. I think of HIV in the 80s. I was just starting college at that point. That's kind of the COVID of that day. Yeah, it was bad. And then the Fogarty International Center, it's part of, like I said, the National Institutes of Health, and supports global health research and training, helping scientists here and around the world. Same kind of thing, doing the statistics, finding out what's causing the diseases, what are these health systems, public health challenges, how can we support people in the United States and these other countries. Again, lots of research, training, funding, helps build the next generation of global health researchers and foster science diplomacy. So when we talk about evidence-based practice, that's what this is. That's where that comes from. These agencies that do all this research, that's where we get the evidence to come up with treatment plans, care plans, protocols, procedures, policies, things like that. So that's why this is so important. National Institute of Health, right? There's the website for that as well. It's the primary U.S. government agency responsible for biomed and public health research. So again, National Institutes of Health research funds and conducts scientific studies on many levels. It's part of the U.S. Department of Health and Human Services, and includes 27 specialized institutes and centers. So it's not just one, it's got all these institutes underneath it. So we mentioned the Fogarty International Center for the research, but that's also NIM, National Institute of Mental Health, the Institute for Allergy and Infectious Disease, NIAID, and then the Cancer Institute, right? So that's only 4 of the 27. And then this also lists for you the focus areas that they have, very similar to those that we've looked at above. Funds over 300,000 researchers in more than 90 countries, largest public funders of science in the world. That's just amazing. Now moving on to major global health organizations. So these are global, worldwide, or organizations that focus worldwide. And so we have already mentioned the World Health Organization, the WHO, and there is their website. So it's the WHO is the United Nations agency, right? So it works with the UN, which has almost all, not all, but a lot of majority of the countries in the world sit there and work on all different kinds of problems, not just health problems, but responsible for coordinating the international public health efforts. So it sets global health standards, monitors disease trends, supports countries in responding to outbreaks. So for example, they had a policy come out when COVID first came out. So we had the CDC telling us what the guidelines were, then hopefully those matched, aligned with the WHO guidelines. But you have to understand that the World Health Organization is looking at it from the global perspective, whereas the CDC was looking at it from the United States perspective. They also have World Health Organization, again, from my other lives as a lactation consultant, the World Health Organization puts out breastfeeding guidelines, as does the CDC. And so hopefully those all align align as well with the international lactation associations, the U.S. Lactation and the World Lactation Associations. Gavi, we mentioned that earlier, the Vaccine Alliance. So it's a global health partnership to increase access vaccines in the world's poorest countries, combines public and private funding to deliver life-saving immunizations at scale. So they are able to expand programs because they can work to create the vaccines, to produce the vaccines, to get them where they need to be, to support people to administer the vaccines, to help people, children especially, get to where they need to get to have the vaccines. And so, yeah, helping with the supply system, supply chain, and equity and access to new and underused vaccines. So I guess I would think HPV, the human papillomavirus vaccine, came out years ago now, but when it first came out, that was a new one. It's often underused. It's used to help prevent the human papillomavirus. It was originally the target population would be females, hopefully before their first sexual encounter, but also was found to help in males as well. So, that would be one thing, or any like the shingles or the different pneumococcal vaccines, things like that. So I think that is just amazing. Global Fund to fight AIDS, tuberculosis, and malaria. We mentioned that as well. So provides grants to fight infections, specifically HIV, AIDS, tuberculosis, and malaria. Doing the research, prevention, treatment, education, access, all those types of things. So I like that by financing community-driven disease programs. I think that's great because that's grassroots. That's really, I think, where the change, that's where the people are, and that's where the change needs to take place. So I think that's a great thing. The World Bank Health, Nutrition, and Population Division. So again, there's your information there, financial and technical assistance to countries for development, major investments in health systems, infrastructure, and policy reform. So maybe not so much here's the vaccine, but here is the infrastructure. Here is a way to structure your health system so that it is effective and we can get the vaccines to those who need it. And policy reform, let's look at the vaccine schedule. These are what you need. These are what we don't need those anymore, or these are the newest ones that have come out. Let's work on getting that structure together so we can get those to the most people, as well as the maternal child health and family planning, pandemic responses, and also helps to reduce poverty and increase access to services. I did put UNICEF in here, the UN Children's Fund, that works in over 190 countries, focused specifically to children and adolescents, health equity, education, nutrition, child protection, which I think is amazing. A lot of the same areas that other organizations have covered. I love the clean water, sanitation, hygiene, those environmental factors that we talked about a few weeks ago, and nutrition programs, I think is great. They work very closely with the World Health Organization and Gavi. So I think that's great. And then I also included the United Way worldwide, and then also gave you information for the United Way Monterey County. We do have a chapter here in Monterey County. So it is a nonprofit entity that works to improve health, education, and financial stability in local communities in over 40 countries. It is more of a grassroots solution as well. And so then there's the information for Monterey County. So that covers the different organizations, how they work together internationally in our country. We talked, in talking about these organizations, we talked about health systems. What is this health system that they keep saying they're trying to create infrastructure for and to help promote a strong health system? So let's take a look. That would be the next part of the lesson. So when we talk about health system is the way of organizing of institutions, people, resources to provide healthcare services. What falls within that category can vary based on different definitions. So it actually gives you, I looked this up several different places, and they all gave us these same definitions. For example, Dartmouth College states that a health system must comprise at least one hospital and one or more physician groups, and the physician group must include at least 3 primary care physicians. So I'm thinking in terms of, I mean, we have what in Tividad, we have Salinas Valley Health, we have Montage, those systems. I guess we could use Montage. It's probably, well, yeah, we'll try Montage. So Montage used to just be Community Hospital, CHOMP, Community Hospital of the Monterey Peninsula. And about 9 or 10 years ago, maybe a little longer than that, decided that they really needed to branch out and become a health system, not just a community hospital. And so that is when they got the term Montage, which sort of is a montage of different pictures. If you think about the word montage, is the coming together of a bunch of pieces together to create a nice little artwork, I guess you would say. And so that system is comprised of at least one hospital, community hospital. It has several physician groups, and there are many physicians in each of those physician groups. If we look at the RAND Center's definition, 2 or more healthcare organizations that are affiliated through shared ownership or contracting relationship. Health system must include at least one physician organization and one acute care hospital. So that's a little, I guess, more specific and wants to incorporate healthcare organizations. So not just hospitals, but organizations. So if we were to combine, for example, Montage and Salinas Valley together, into a health system, then that might meet that definition. There's similarities across the definitions. You have to have generally a hospital and a physician group, and you've got to have some kind of affiliation. Integrated delivery networks, right? The health system to integrate care across organizations. So if you think of Montage has many clinics that you can go to. Their express care places, the emergency, besides the emergency room, they have they open them up all over the place now, the clinics that you can go to, and they can help to coordinate. I can go to one in Carmel, but I can also go to the one in Marina. There's one in Monterey, but my health information is shared, so that continuity of care is very important. So how does a health system improve care? If we didn't have a health system that had these groups of physicians and hospitals, what would we do? We would just probably go to the doctor, and then I don't know what would happen after that. Excuse me, I remember back in the day, I went to one pediatrician. My mom took me to the one doctor. He actually did house calls. He lived up the street from us, and he would come down and take care, come see me sometimes when I was sick. But my father always went to the same doctor, always in the same. We only went to community hospital. My mom had specific doctors. They really didn't have healthcare systems. Stanford was a healthcare system, if you will. But now we have them here locally as well. And so what is this? How can a system help to improve healthcare? Well, the critical functions that the health system carries, it carries resources, right? If you're just one place, you don't have as many resources as you do when you combine resources together. The provision of healthcare services, I would say, on many different levels: preventative healthcare services, primary, secondary, tertiary prevention services. You are just on fire tonight, aren't you? Stewardship, meaning advocacy, that would be another word for advocacy. Through their system, they can refer you, they have education, they have durable medical equipment, they have a lot of different pieces of the puzzle that they can connect you to. Yes, you may go to different people, but it's all within this health system. And so the other nice thing is that through HIPAA, the Healthcare Portability Act, that your information is shared in one place, so that, for example, I went to my eye doctor a couple of days ago, and they're like, would you like us to send a report to your primary care provider? I'm like, yes, please. My labs are all in there. Everything is right there for anybody to look at. If my primary care provider is not available, if I can't get an appointment, the nurse practitioner can see me, and all of my health information is right there in case I forget something, or if I need to be admitted to the emergency department, all my information is right there. And so this health system then is trying to provide equitable access to healthcare and promoting and improving health for all. So if you are a system, you are not just in one place. Like I just said, Montage has centers or clinics, Pacific Grove, Carmel, several all in those areas. There are a couple in Monterey, Seaside, and they're building new ones all the time, which is a good thing. And then health systems governance, who oversees these health systems? So what process, structure, institutions are in place to oversee and manage, for example, a country's healthcare system? Because if you think of a country healthcare system, that would be, for example, like Medicare. Or we talked about Medi-Cal, which is Medicaid, but Medi-Cal for those of us in California. So different people, different stakeholders that are involved in healthcare, including the government, the healthcare providers, patients and family, even communities, organizations, private sector people, private sector. And so hopefully having health systems governance means that there is a strategic plan to ensure that the healthcare services are that there's access, that they're equitable, efficient, affordable, and high quality. That goes back to social determinants of health, right? Access to quality healthcare is one of our social determinants, right? And so hopefully equity and social justice is being provided. So if I have a healthcare system and I have a governance body, say a board of directors or whomever, that is responsible for overseeing that, we can do research to find out where do we need to put more clinics, what types of doctors, what specialties do we need to have? Is there a certain population that we're starting to see more of, perhaps, for example, more Hispanic speaking, Spanish speaking clients? So maybe we need to hire more Spanish speaking providers, things like that. And so then I gave you an article. This is the introductory piece of it, and then the link to the rest of the article on health policy is here. But comparing health systems internationally around the world. So hopefully our health systems, I mean, that's the goal. That's why we have a system, is because we want to provide accessible, high quality care to as many people as possible and have it be affordable. And so to see how we are doing in the United States, we want to check ourselves against other countries. Other countries want to check themselves against us and other countries as well. So if we compare health systems, each country, because if you think there's political, economic, social conditions, we still look at social determinants, but there's different ways of looking at them in different countries. We have different funding sources. So this particular chapter in this book does look at comparing and seeing what do it compares actually Australia, Austria, Belgium, Canada, those countries, and the United States, as well as the United Kingdom. And so again, the theme is coming back that despite spending far more money than any other peer nation, wealthy nation, considered wealthy nation, Americans live shorter lives, face more barriers to care, inequitable care. And so why? Where is that disparity coming from? And so that can be attributed to different aspects of our health system, for sure, we know that, but also social determinants of health. So if you go, I like this kff.org, it's a good resource, and will give you an international comparison. And I have that in the next tab as well. And so one of the ways that we can help, we think of universal healthcare. You hear that term often. Why doesn't the United States have universal healthcare? What is universal healthcare, right? It means that everyone can access health services that they need without financial hardship. And so it's generally public or a heavily regulated insurance. Coverage of essential services, so it will cover only essential services, which is okay because essential services are essential. Strong role for government in funding or oversight. So often universal health care, the oversight is from the government. Emphasis is on preventive care, not just emergency treatment. So at one point, the United States, gosh, 80s, maybe 90s, I think 90s when I was first starting out as nurse, we were very reactive. Oh, emergency. Oh, there's this trauma. Oh, there's a chronic illness that now has had an exacerbation, gotten worse, like an asthma exacerbation, COPD, chronic obstructive pulmonary disease exacerbation. And so we're going to treat that here in the hospital. Well, hospital costs just skyrocketed. And so we thought, well, what's the best way to, what can we do about this? Well, we did managed care organizations, HMOs, to kind of talk about the funding, and see if we could help streamline that as well. And then we also talked about preventive care. So could we start before the person even gets sick? Could we talk about what, if they have chronic obstructive pulmonary disease, how did they get there? It might have started out as asthma. It could be because they were smoking. Oh, smoking. Well, let's try and keep people from smoking, or explain to them, educate them about the dangers of smoking and what could eventually happen to them. So that would be preventive care. And if you can expand, at least in my personal opinion, if you can expand on preventive care to keep people from getting sick in the first place, or recognizing that they're sick earlier on and can get treatment, then that would save tons of money. You wouldn't be treating them on the back end. You'd be treating them up front. And so I think that is a good way to do it. Do we need universal health care to do that? I don't know. That might be a good way to do it because it sounds like a lot of other countries do it that way, and that they're pretty successful with that way, using that way. But it is heavily regulated and run by the government. So that does not promote, I don't want to say capitalism, but competition, which can sometimes then decrease prices. And then how does universal health coverage work in terms of health policy? So there's I believe takes us, to a health systems features. So what are features of some of the health systems around the world? By Australia is that color? I have no idea. But this article is from the commonwealthfund.org, which I have used as a reference a lot in this lesson. And it goes through these countries alphabetically and talks about their health system features. What do they have? And so talking about Australia, talking about Brazil, you all can read through there and see what all the differences are, but this might be helpful in your comparison worksheet that you have to do. You can, use these references, do some research on your own. What about, oops, Canada? Let me stop sharing for a second because I'm not sure that is going to stay on there. Let me come back to that. There we go. Because I hit the wrong button. There we go. Canada. So we talk about Canada's healthcare system a lot. Do we want to be like Canada? So it is a universal publicly funded healthcare system funded through federal legislation in 1957. So that's a long time. And again, in 66. It looks like the Canadian Health Act of 1984 replaces those. So it sounds like it's getting updated and updated as times change, which is probably a good thing. You can receive full federal cash contributions for healthcare. So they have territories in Canada, not states. The insurance plan needs to comply with the 5 pillars of the Canadian Health Act. And so it's got to be publicly administered, comprehensive, universal, portable across provinces. So for example, if I go from Saskatchewan to Manitoba, I should be able to still use my insurance. It should cross over, and accessible. So without user fees. So like no copay. China universal coverage in 2011 through 3 public insurance programs. So they came up with some new types of insurance programs. Denmark, all registered Danish residents, so Danish citizens that have come into the country legally, are automatically enrolled in publicly financed healthcare, which is largely free at the point of use. And so it does say that registered immigrants and asylum seekers are also covered, but undocumented immigrants have access to acute care services through a different source. So there is some choice for that. You have healthcare coverage in England, and I don't know where I put that. I was looking for her BART caller. Should be quiet now. So England, National Health Services under the National Health Service Act. So that's been around since 1940s. It's a really long time. They've updated it again and again. They have a Minister of Health, automatically entitled to NHS National Health Service care. Still largely free at the point of use. France, same thing. So with these countries, it gives you all the different thoughts and ideas behind their universal coverage of healthcare. We're actually, the United States is one of the few countries, or a few of the wealthier countries, that does not have universal healthcare, which a lot of citizens are really talking about and wanting to promote. So that's one way that we all can advocate. We can talk about Taiwan. Taiwan has one of the best medical systems. That really surprised me, but it does. And then the United States does not have universal health coverage. Nearly 92% of population was estimated to have coverage in 2018, leaving 27, which is not bad. 92% is pretty good, but that equates to 27.5 million people, or 8.5% of the population, that are uninsured. And so Medicare, Medicaid came about in 1965. You've got many different employer-sponsored health insurance programs. This talks again about Medicare, Medicaid, Children's CHIP, the CHIP program, Children's Health Insurance Program, the Affordable Care Act, and what that is helping to cover. And you can read more there. And I was thinking of something, and now I can't remember what I was thinking. So right now at Hartnell, our faculty insurance, they've increased some prices, some co-pays, they've dropped some coverages, and so we're actually considering moving for the first time in many, many years to a different system of insurance for our faculty. So it is nice to have choice, and I feel good that somebody at the college is looking out for us and making sure that we are getting the care that we need, which is a good thing. What else okay, that's where we were. So universal health coverage and socialized medicine. So one of the questions that we get is, what is the difference? Aren't they the same thing? And so they're often confused, but they're actually distinct approaches to healthcare systems. So socialized medicine is a system, as this says, where the government funds and often operates healthcare services, where universal healthcare is a broader concept focusing on ensuring access to healthcare for all citizens, using different models. So for example, socialized medicine, the government owns and operates the healthcare facility, right? Because where the government funds and operates. So socialized medicine has to do with the government funding the system. So the government owns and operates the healthcare of the hospitals, the clinics, employs, like you work for the government, employs the healthcare professionals, funded through taxes. The British National Health Service would be an example. It's a single payer system where government is the sole insurer and provider. So there isn't really any choice, but because it's run by the government, funded through taxes, I feel like there's a better eye on what's going on. And if changes are made, it's not here or there, it would be everywhere. Universal healthcare, access for all, ensures that citizens have access to necessary healthcare, funding through various different sources. Examples would be Canada's Medicare system, Germany and Singapore are examples, guarantees access to a defined set of healthcare services. So to those primary care services, that was when we looked at our definition, it was the primary care services. not specialties, but primary care. So the key differences between universal healthcare and socialized medicine would be that socialized medicine involves government ownership. The scope to socialized medicine is a specific type of system, while universal healthcare is a broader goal having to do with access to healthcare, and they can both be funded through taxes. Universal healthcare can also incorporate other funding sources like employers or private insurance premiums, which we have that system. So one would think it might be a little bit easier to have universal healthcare. And then what I wanted to look at with you is we've mentioned several times now that although we spend the most money per capita for healthcare, we have some of the worst health outcomes in our country. So depending on what statistic you look at, spending over $4.5 trillion annually, US ranks last among high income countries on nearly every major health outcome. And I do have pictures of that following here. And so if you look at these, yeah, here we go. Look at these. So these are specific. Remember, we talked in the very beginning about maternal mortality, life expectancy, infant mortality. So life expectancy by country. And these statistics are from 2025. This is the source there. And so this goes on for like 200, 201 countries, something like that. And so if you look here, this tells you the rank, right? 1, 2, 3, the country that is there. So Hong Kong, Japan, South Korea are at the top there. Life expectancy. So it has the average life expectancy, and then it will give you the female life expectancy and the male life expectancy. I don't believe there's been enough time yet to talk about transgender or people that are transitioning, but that might be an interesting statistic to look at someday. And so life expectancy would be, so people in Hong Kong, let's say 86, live to be 86, on average 86 years old, mid 80s, right? All in there. And some of the, like French Polynesia, that's a teeny tiny country. Singapore, Reunion, Malta, tiny little countries. France, 83, United Arab Emirates, 83, Ireland, 82, Israel, 82, Qatar. I haven't seen the United States yet. Have you seen the United States yet? No. New Zealand, 82, Austria. Where was Canada? 82 for Canada. New Zealand, Austria, Denmark, Greece, Puerto Rico, UK. So Germany and UK at 81. Bahrain at 81 years old. Taiwan, who has a good health system, apparently, according to statistics. 80. 81, let's say 81. I still haven't seen the United States. There we are in the United States, 48th. I will tell you that I have been teaching this particular statistic for a long, long time. We've not moved a whole heck of a lot. I think when I used to teach this, we were maybe 55 in the low 50s, where we were hovering right around 50, 51, 49. And this is what, 10, 20 years later, we're only at 48. We haven't really improved. Our average is 79 years, women, 77, men, 82. So it's just interesting. I would think we would live a little bit older, longer. But I did want to continue down here. So we were 86, I think, was the top. If you look down here, there's Uzbekistan, Iraq, El Salvador, India, Tajikistan. So 72, we're in the 70s, Cambodia 70, Nepal 70. Philippines 70, and then we drop before 70 years old, and we still have more to go. Ethiopia 67, Zambia. So these are African nations. South Africa, Afghanistan, Ghana, Congo, again more African nations. Angola, Madagascar, Kenya, Mozambique, Zimbabwe, and then we get down to Nigeria, 54. 54, 55. That's like a 30-year difference of life expectancy, which I just think is real, just really makes you go, what are so many factors that probably play into that, but it's just I just think it's an amazing statistic. And so then if we continue, we can look at let's look at maternal mortality, and then we'll look at infant mortality. So again, moms that that die. And so this is actually a map, which I think was kind of cool. So this is maternal deaths per 100,000 live births. This is from 2025. So this is actually so maternal mortality declined by 40% between 2000 and 2023, which is amazing. It's been a goal to improve, and I think that is amazing. And so less than 70, what do we do per 100,000? So less than 70 deaths per 100,000 is this dark blue color. So that would be North America. Yeah, but see Africa's in there, 220 to 1,000 per 100,000 live births. That's just staggering to me. And so the article talks about different trends and ratios according to different countries. And I always think that's kind of interesting to look at. And but I'm really excited that we've really gotten better, because it was scary there for a while. And it talks about different causes of maternal death. So looking at abortion, hemorrhage, hypertension, pregnancy-related infections. Still have you can have sepsis, sexually transmitted diseases. Hemorrhage can happen at any point during the pregnancy, can even happen a lot postpartum. I've seen a couple of scary instances where we weren't expecting it. And I remember one this last semester. Mom was ready to go home. She stood up to go to the bathroom, and basically like blood just gushed out. She was having a postpartum hemorrhage. And so we got everything done and saved her, and that was great. But you just never know. So I think it's interesting to look at those statistics and references when looking at maternal mortality. And I don't know, why would the United States have a high maternal mortality? Many people think that it is an equity equity issue. Let's look at the infant mortality. I think I had, yeah. So infant mortality, so that's deaths among children younger than 1 year of age, sorry. And so the rate is not improved at the same pace as for the US. It's not improved as much as it has in other countries. So these would be deaths among children younger than 1 year of age. And it doesn't give me reasons for the death. It also does break down some of the states in the United States, almost as if they were countries, because that's where their number falls. So out of 38 countries, the US ranks 33 out of 38. So you can see that Sweden, Italy, Denmark, Korea, Austria, all have less infant death. Germany, Luxembourg, Sweden. Vermont is not too bad. But if you look at the average, so this is the average of the countries that they are looking at, the average is this 4 deaths per 1,000 live births, 4 deaths. But the United States is at 5.4, and Mississippi is even higher than that, 8.4. What is going on in Mississippi? We need to take a look at that. What is going on in Mexico and Colombia that they're having so many infant deaths? And this talks about life expectancy. These are just more statistics there. Total health spending gives you some different ideas there. You can look at the other statistics. We'll pull that up one more time. And I just wanted to show you those, because I think it's kind of surprising. Sometimes we think that, or some people may think that the United States is just we're a wealthy country, and so we do things really well. And there are some things we don't do really well. This talks about hospital admissions, access to primary care, and chronic disease management. There's a couple different options there for you to look at how chronic diseases are managed in the United States and other countries. Why? Why is the United States? Why do we have such trouble with this? Well, we lack universal coverage. We don't have universal health care. So there's many people, millions, that are still uninsured or underinsured. It's almost impossible if you are middle class to get insurance. You can't afford, you're right in the middle. You don't meet the poverty, not that you would want to, but you don't meet the poverty cutoff, and you don't make enough money to afford your own insurance. So you're really stuck in the middle there. It's healthcare is profit driven, right? And so the hospital has to make a profit, the doctor's office has to make a profit, everybody has to make a profit. When you have to make a profit, then I think care goes out the window, right? Your care, your compassionate care, and equity goes out the window. Public health is underfunded, right? Prevention is undervalued. Like I was telling you, there was a point in time when prevention got moved up to the top, and then for some reason um, went down to the bottom. I don't know. I don't know what happened. I believe it was with managed care and looking at ways to cut costs. Racial income-based health disparities are still widespread, and policies focus on treatment and not prevention, or the social conditions, the social or structural determinants of health. Um, and so best healthcare in the world, this is a picture that I took for you. Best healthcare in the world, Singapore. And if you go to the website, it will give you the criteria that they were measuring. United States, 69th in best healthcare in the world. Yeah, that was from International Citizens Insurance. Commonwealth Fund, again, this is one of the ones I was talking to you about, looking at these 10, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 countries, right? And looking at the overall ranking. This is from 2024, looking at what? Australia, Canada, France, Germany, Netherlands, New Zealand, Sweden, Switzerland, UK, and US. We are last in every category except our care process. If our care process is so good, why are we so bad in all the other categories? It just amazes me. Austria, sorry, Austria, not Australia, right? Australia, Austria. Oops, come back. There we go. Number one, Australia, Netherlands. UK is number 3. Now they don't do so great with the care process, but they're good in other things. The administrative efficiency, we lack administrative efficiency. It's just the bureaucracy of things just kills me. Look at that. We are number 9th in equity. I don't think Sweden looks at equity because they're equitable. Health outcomes, 10. We're terrible. Why? Does it have to do with capitalism? Like because things are for profit? The United States lags its international peers on health system performance, right? So the top 3, these top 3 countries, that's their average. And these other countries, guess where the United States is? Boom. Way down here. And you can go to the source and see how they conducted the study. And this is just some other links that you can go to get more information. But I just think it's really eye-opening. And so when you think about environment, all the things that we've talked about, access to healthcare, the social determinants, structural determinants, what can we do? How can we advocate? What do we have to do? What do we have to change? Are there things that we do well that other countries could could take away? Are the things that we could take away from other countries? So let's look at infectious and chronic disease management, because we looked at the overall system. Let me stop sharing one more time and then make sure that I am in fact on the correct screen that I would like to be. Yep. Okay. And so we're going to look at these health systems in terms of how they manage infectious and chronic diseases. So we had earlier defined infectious diseases. And so how, if you think prevention first, which is what most of the countries are doing, or many of the countries are doing, that would include vaccination programs, having access to vaccinations. So run through these World Health Organizations. Vector control, the vector is the organism that carries the disease. So when you think about mosquitoes, for example, they carry diseases like malaria and dengue fever. And you have to actually get vaccinated against malaria and dengue fever when you're going to countries where those diseases are prevalent. But if they have spraying and nets and the vaccines, vector control. Water and sanitation efforts, again, clean water projects, right? So prevention, not waiting until they get the diarrhea. We don't want them to get the diarrhea in the first place. Let's find clean drinking sources. Let's dig wells. Let's get filtration systems. Education, community-based outreach to teach hygiene, HIV prevention. The best thing to intervention to prevent disease is hand washing. That's like number one. And then early detection and reporting. So especially for things that are pandemic prone, like COVID-19 or Ebola, right? So those are prevention strategies, which I think is great. And so then I give you a case study to compare and contrast the US and in this case, South Korea, and how the responses were similar and different in terms of COVID-19. Now you can read the stories and go to the resources. But let's take a look. What did South Korea do? We know what the United States did. What did South Korea do? So they had a rapid, so a quick, centralized public health response. So a quick, centralized, meaning like a focused from one place health response. They did mass testing that was rolled out immediately. You could do drive-through and walk-up testing centers were available within weeks of the first outbreak. It tells you up here that the US and South Korea reported their first confirmed cases on January 20th, 2020. But their trajectories of the disease process were much different. So they started the testing centers available within weeks. The contact tracing. So contact tracing means going back and figuring out who was patient number one or where did it come from, and if you have it, where who have you been in contact with. So the movie, I believe it's Bang the Drum Slowly, is a good one that talks about patient number one for the HIV crisis that occurred. So it's the same type of thing. We have much better technology now than in the 70s and 80s. They did isolation and quarantine for positive cases were strictly enforced with government provided housing, food, and income support. So they basically quarantined them, put them places, and took care of them. Free COVID treatment for all citizens and residents, regardless of income or insurance. So everybody got treatment, no questions asked. And unified national messaging, so led by health professionals, not politicians. So the goal was to control the spread without full lockdowns and keep hospitals from being overwhelmed, both of which we experienced in the United States. So how did that happen? So we'll compare and contrast. So we had a fragmented and delayed response, according to these statistics, these stories here. So testing shortages, if you're looking at these same things, we're going to look at the testing. Testing shortages, delays in ramping up widespread diagnostic availability. It was hard to get a test. You had to make appointments. You couldn't get access. You couldn't get a hold of tests. Some places required testing, other places didn't. Our nursing students were able to go to facilities, but we had a test every week. But even finding tests was difficult. We had a slow initial response at the federal level. And so states were left to design their own strategies. The states didn't know what to do because they didn't have guidance from the state, from a central, location. And if I remember correctly, when we got guidance from the CDC and the World Health Organization. They differed a little bit. No lack of the national mask or quarantine mandate, so led to inconsistent implementation. There was hospital overload due to limited surge capacity. So all these people got sick. And the thing is, we didn't know what they had. So we had people coming in and we thought it was one thing and then it was another. And it was just awful. And then the vaccination rollout came out strong in 2021, but then slowed, if you recall, to vaccine hesitancy and misinformation. So people didn't want to get vaccinated. There was misinformation. And then also, if I recall, there was a shortage of the vaccine and it was mandated. You were told you had to take it. So the goals varied by state. Some wanted to reopen economies and others prioritized public health, depending on how you think about that. But I would have to agree that in the United States, it seemed to be more of a politically run decisions were made as opposed to the centralized response in South Korea. And so what happened if we look at the outcomes, right? This is based on World Health Organization, CDC, and Korean disease control. So how many deaths per 100,000, we'll look at United States. So 2020 to 2023. Now understand that these statistics may or may not be skewed in the United States because we then went back, many of our deaths were listed as COVID deaths, but were actually as a result of a chronic disease process, which made the person more susceptible to COVID. And so 58 deaths per 100,000 on average, and over 340 for us. Confirmed cases as of mid-2023, 30 million approximately, triple, right? Triple and a half, 3.5 times, 106 million confirmed cases. Healthcare system overload, they did not really have in South Korea. We had multiple waves of overload. The resilience of our healthcare workers, God bless, because it was awful, absolutely awful. And then when people wouldn't get the vaccine, they were fired. They were let go, whatever you want to call it, which then decreased the staffing and placed more burden on other people. Vaccine uptake, right? So in South Korea, it sounds like there was a lot of information. The vaccine was available. They did really good education on it. Whereas in the United States, it was mixed. There was a high initial uptake of the vaccine and then a sharp decline due to hesitancy and some would say misinformation. And then the economic impact, South Korea managed to do without lockdowns, whereas we had major shutdowns, job losses, and stimulus. We needed stimulus programs to get back on our feet. So again, to me, that's more of a political or government type issue than a health issue. And so then if you look at the key, well, what was different? And so then it gives you, which we talked about, universal health coverage, the centralization of the care, the public trust in health officials generally high. And they also, the pre-pandemic preparedness, South Korea had dealt with other multiple resistant organisms, breakouts of those pandemic type things. And then we didn't have pandemic ready infrastructure. We were lacking there. And then there's just some questions that are posed here. Y'all can read through that for yourself. That have to do specifically with that case study and how we think about inequities and how that affected us. Just things to make you go, and think, and how can we, what if this happens again? Like, are we ready? Are we prepared to deal with this? And so then there's also one here, I give you a case study talking about chronic diseases and the growing global challenge. So chronic diseases tended to be thought about in wealthier countries. If you think about hypertension, diabetes, also called non-communicable diseases, but now they affect every region of the world, right? And they're rising fastest in low and middle income countries. So what in our world is changing that is making this happen? It's really interesting to me. And so key global strategies, taxes and regulation. Mexico had a soda tax. I know in New York, they were saying you couldn't get like supersized things. You don't only get so much on the soda, so many ounces of soda. Tobacco laws, you can't smoke anywhere in California anymore, hardly. And warning labels. There's warning labels to tell you what to beware of. Community-based screenings. We do a lot of, that's one of the things in the nursing program that we really try to do is help with screenings, blood pressure, diabetes. You can do cancer checks, like colonoscopy, different stool samples, things like that in rural clinics, because that's an access issue. Other key global strategies, task shifting, so training non-doctor people. We talk about community health workers in this particular case study to manage chronic disease care. International guidelines, they have the World Health Organization. Best Buy has recommended low-cost, high-impact policies for the non-communicable diseases. So there are international guidelines that these countries are following, and they don't really deviate from them, and they work. And then integration with infectious disease care. So how do we put the infectious disease and the chronic disease together? So there are clinics, physicians, healthcare professionals that are managing people that have HIV as well as diabetes or another chronic illness. So there's another case study. This one has to do with Rwanda. And task shifting to manage chronic disease in rural clinics. So they, because access to healthcare is, every place is pretty much rural. And so they trained people to be community health workers to support chronic disease care. And so nurses and community health workers are trained to monitor blood sugars, blood pressures, meds, make sure people are taking their medications. They have HIV infectious disease clinics. And so they integrated a chronic disease level in there. And then this I thought was interesting, use of mobile phones to track patient data and follow-ups. That increases access. So I thought that was brilliant. And so the outcomes, they saw increased access, higher rates of disease monitoring and medication pickup. So you had access and were able to pick up your medications, and better long-term management in this particular case. And so their model demonstrates how task shifting and integration can expand care access even in under-resourced settings. We can get somebody there, we can help you. What's the United States done? Have we tried community health workers? I don't know. Would that be something? Yeah, we have. I know even at Hartnell in the nursing and health sciences department, we had looked at opening or working with a community health worker program. But it's I don't know. I guess I would want to say it's looked at like, are we taking away? Are we taking away from medical assistants? Are we taking away from nurses? How trained? We ask what's the criteria? How trained are these people? And the approach is more fragmented. So we'll try it here, but not here. Like there's no one place that says, hey, let's do this or do that. And there's not a funding source, right? So if we wanted to put this particular program together in the nursing and health sciences program at Hartnell, we would have to write a grant for that. There's no other funding source for us for that. Or develop a nonprofit partnership with someone. So this describes what they do, names that you might hear. They're frontline public health workers, trusted members of the community. So they're in the community already, so people trust them, and they bridge the gaps between culture, language, and so to help people understand and educate them about their disease processes. And so this gives you different roles and different programs that like CDC does use that. Medicaid programs, not Medi-Cal programs, Medicaid programs use that. And there was some talk and work during COVID to implement a community health worker workforce initiative. And so what are barriers? Funding. It's always money. It's about the money. Inconsistent funding. It's time limited grants, right? And lack of standardized training and certifications, right? How do I know that you're competent and you're not? How do we know this? How do we measure that? Limited insurance reimbursement. Insurance won't cover community health workers, kind of like being a lactation consultant. Many insurances don't cover lactation consultants, and not fully integrated into mainstream healthcare teams. They're not part of the team. We don't see them as that. So are we missing an opportunity? We might be, especially in rural communities. So just some more questions to think about and ask yourself about those questions. And so that's basically the 4 prongs of that lesson. And so now we want to bring it all together at the end. I've taken up enough of your time. And so again, brought together many concepts that we've been talking about across these 8 weeks. And also, I think this particular lesson provides a lot of opportunity for advocacy, ways for you to think of how to be an advocate, or to find something that speaks to you that you're passionate about and make that your cause, and find a call to action. So global health disparities, the infectious and chronic diseases, universal healthcare models versus other healthcare models, our role in health equity, which we're not doing a very good job of, and we learned about the international organizations as well. So that's how we met those particular lesson outcomes. Here are the key concepts that we started out with at the beginning. This is the description and examples of those. And then just some more questions to ask. How do we compare to other high income countries? Well, we spend more money and we have worse outcomes. Are there any particular diseases that are most prevalent globally? Chronic diseases, we're starting to see more and more of those in all over the world. Are there any particular policies or systems that seem to be working? Some of those case studies, those examples we gave. How are infectious and chronic diseases prevented and managed? Well, we don't really talk a lot about prevention. We think we do, but I don't know as we do a very good job with that. But there has to be support for the education, not just one person going out and trying to educate as many people as they can. And then these are just some of those examples of different strategies and policies. what might we be able to learn or other countries learn for us. And then I found this article that talked about where we rank in terms of equity, and we're at the bottom, which I thought was really interesting. So here's your call to action, right? As a social justice advocate, how will you make a change moving forward? That's my call to action for you. How will you make a change? So that would be the lesson. I know it was a long one. There was a lot of different facets and aspects of it. But I think it's a really important lesson. I think it will give you maybe some ideas for your advocacy projects or ways to look at them. And I hope that if you have questions or anything, you can message me, make an appointment. I'm happy to talk with you. And I'm hoping I will be in the discussions, and I will see you later. All right. Have a great weekend.